Hello everyone, welcome to the short notes series. In this set of video, we will be discussing how to write a 5-mark question when asked about a given topic. Today we shall discuss about Reye Syndrome. So what is a Reye Syndrome? Reye Syndrome is a rare condition which is potentially fatal that causes acute encephalopathy associated with a hepatic dysfunction primarily in children. Eponymous means after whom it is named after. It is first described by Dr. R.D. Reye in 1963, who observed sudden vomiting, confusion and coma in children recovering from viral infection usually. The hallmarks of this feature are microvesicular fatty change in liver as well as cerebral edema. Coming to the pathogenesis. Exact cause is not fully known, but it is assumed to be linked with mitochondrial dysfunction. Mitochondrial dysfunction impairs the beta oxidation of fatty acids, which will result in accumulation of fat in the liver, brain, which will result in fatty liver and cerebral edema. It leads to hyperammonia, hypoglycemia and raised intracranial pressure. It is strongly associated with the use of aspirin during viral infection. The predisposing factors include viral infections like influenza A, B and varicella, use of salicylates, that is aspirin, during or after the viral infection, genetic defects in fatty acid oxidation, that is MCAD deficiency, metabolic stress, infection increases the risk. Coming to the clinical features, it typically occurs 3 to 5 days after viral illness recovery. Persistent vomiting, irritability and lethargy are the early features. Late features include confusion, seizure, progressive coma due to encephalopathy. Signs include hepatomegaly without jaundice, raised intracranial pressure, decerebrate rigidity in severe stages. So it is described in stage 1 to stage 5, where it will progress from a simple vomiting to coma. So in stage 1, there will be vomiting, laboratory evidence of liver dysfunction, lethargy and sleepy. Some books suggest if there is no clinical symptoms but presence of laboratory evidence, they call it as stage 0. Now, stage 2. It consists of deeply lethargic restlessness, confused delirium, combative hyperventilation and hyperreflexia as symptoms. Stage 3. Uptended or in light coma, then decorticate rigidity. So these are called as moderate symptoms, and here we will have severe symptoms. So here in stage 4, there will be deepening coma, seizures, decerebrate rigidity, fixed pupils, loss of oculovestibular reflexes, and in stage 5 there will be seizure, deep coma, flaccid paralysis, absence of deep tendon reflexes, respiratory arrest and fixed or dilated pupils. Coming to the investigations to make out: liver function test to check for raised AST, ALT and ammonia, hypoglycemia due to hepatic failure, prolonged prothrombin time or INR due to reduced clotting factors. CSF will be usually normal, helps to differentiate between meningitis and encephalitis. In liver biopsy, there will be microvesicular fatty infiltration without any inflammation, and brain edema on CT or MRI can be visualized in imaging. The complications: there will be a 20 to 50% mortality rate depending upon the diagnosis stage as well as intensive care that is available. Death usually results from cerebral edema, brain herniation or multi-organ failure. Long-term neurological sequelae include learning disabilities, behavioral changes, memory loss, seizure, ataxia, speech impairment due to hypoxic brain injury. Hepatic effects include transient hepatomegaly or elevated liver enzymes. Other complications include renal dysfunction, pancreatitis, gastrointestinal bleeding. This may occur during. Coming to the management, unfortunately, there is no specific cure, only supportive and intensive care management is there. Maintain glucose with IV dextrose to prevent any hypoglycemia. Control of cerebral edema by hypertonic saline or mannitol. Correct the metabolic acidosis and electrolyte imbalance, avoiding hepatotoxic drugs and mechanical ventilation if respiratory failure develops. Coming to the prevention, avoiding aspirin in children or adolescents after any suspected viral infection. Educate the parents and healthcare providers in early recognition. Monitor children with viral illness for persistent vomiting or altered sensory. To summarize, it is named after Dr. R.D. Reye, and the pathogenesis involved mitochondrial dysfunction with fatty liver and cerebral edema. Key feature include acute encephalopathy. This trigger is usually aspirin ingestion after a suspected viral infection, and the treatment includes a supportive treatment mainstay and glucose and ICP, that is intracranial pressure management. Avoiding aspirin in children is one of the preventive strategies. Hope you have learnt about Reye syndrome. Thank you.